and therefore we need some Gyan from Vishma Pitamah. Vijay, I think the number of questions which were asked at the end were like arrows which were getting the Vishma Pitamah. Everyone has to learn which one is right. So it's best to now talk.
Yes, start with it.
Well, the chairperson from P.P. Verma is going to take the stage again. Dr. Sapna Mehta from Mumbai. Dr. Kher, you start.
It's part of the above. Huh?
So let's be very fair and not really what this talk about.
I thought this part should be above 80.
What do you think of long?
What can you need to put on it?
I think it's a pleasure and honor to chair this or moderate this session of Professor Kher. You all know that he is a revered teacher, one of the most respected nephrologists of the country, and a true scientist. I think he has compared, Dr. Umesh Khanna has compared him with Bhishma Pitamah, because Bhishma Pitamah and he, I think there are 2-3 similarities. Though Bhishma Pitamah, when he became famous, he was 175-year-old. It is said that in Mahabharata times, because of the good environment, no pollution, average life expectancy was 200 years. Mind you, as per Mahabharata, Arjun was 55-year-old when he fought Mahabharata. Krishna was 83-year-old, and Bhishma Pitamah was 155-year-old. Yeah. So, and your question, how many arrows? There were 6 arrows which formed the, which were shot by Arjun.
Dr. Verma, are you sure the age of Krishna and Arjuna this?
This is what is given in the mythology books.
And they are good friends, you know. So.
I know. I think the true traits of Bhishma were, he was very sane person and he was respected by everyone. Everyone used to go for advice to him. That is what is with Professor Vijay Kher. He was master of all the weaponry, Bhishma Pitamah. It is not only that bow and arrow, it was not only sword, it was not only spear. He was master of all the weaponry. I think that is true for Professor Kher also, that whether it is clinical nephrology or transplantation or ABO, and whatever you talk to him, he is master of all weaponry. I don't know what he is going to talk to, but in a short time, I request that whatever he will talk, that will be Gyan for all of us.
Well, good evening, ladies and gentlemen. I know I'm standing between you and the dinner, and I feel somewhat guilty of this talk being given at this point of time, but that's what Umesh has said, and I am thankful to all of you for giving me these titles, which I don't think I really deserve, but what I have sort of decided to talk today was that what I do not find in a nephrologist prescription. I've been practicing for 40 years, and over the last few months, I've been looking at, because I get now that you're getting older and you get patients who have been seen by nephrologists. So you come, you get these patients coming for 2nd, 3rd, and 4th referrals to me, and I get to look at the nephrologist prescriptions. So, and I've sort of looked at these, and when Umesh told me that you need to come for this conference, you missed it last time. So I told him that, okay, I'll come. But he said that, what are you going to talk about? So I told him maybe I should talk about this. It is after I had told him that I'll talk about it, then I started looking objectively about these things. This has been a perception that nephrologists, I have been finding that there are some things which I feel that nephrologists don't usually sort of do it. Was 100 prescriptions of glomerulonephritis, acute kidney, probable causes of chronic kidney disease who had come for second or third. Nephrologists would consider as a significant independent risk factor for almost mortality, cardiovascular mortality, progression of kidney disease, as well as for end-stage kidney disease. But what I find is that quantification of albuminuria, urine routine examination is obviously, people come with these routine examinations, but when you look for, I had been actually, this was my impression to start with, that I had to search for quantification of albuminuria in prescriptions or in the reports of the patients. And I took 10, 15 minutes to look for where is it? Otherwise, this should have been something which should be probably be most commonly found. But when I analyzed, I was myself surprised that quantification of albuminuria by any of the methods, urine protein creatinine ratio, albumin creatinine ratio, 24 hours was 21%, use of ACE or ARBs, 17%, SGLT2, most of these 24%, it was started by endocrinologists, finerenone 6%. Assessment of iron, EPO was given in almost 80 to 90% of these patients, but assessment of iron status had happened only in about 22% of patients. Vaccinations, 17%, bicarbonate levels 0.2, although doses was given in almost every patient. Majority of the patients were on a soda bicarbonate repletion therapy, but bicarbonate levels were not. You found a lot of keto analogs and all being, but assessment of nutrition or even a mark about malnutrition, that there is no malnutrition or there is some evidence of, was not evident at least in any of the prescriptions. So I found this to be somewhat, and each one of us, I don't have to show it to you, albuminuria is a risk factor, a progressive risk factor for cardiovascular mortality. Even small increments of albumin from 5 to 30 milligrams is also important for this. And this is again showing the same. And these heat maps are very well known that they, even in a normal GFR, albuminuria is. So albuminuria is an independent risk factor for the things that I talked about, kidney failure, ESRD progression and all that. And ACE and ARBs actually are important. So class 1A for not only for diabetic, but even for non-diabetic kidney disease. But use of ACE and ARBs just because there is a fear of hyperkalemia. In all the studies that have been done on ACE and ARBs, the maximum percentage of hyperkalemia was 14%, not more. So which shows that probably in more than 80% of our patients, we should be able to use, and we don't monitor potassium that well as it has been done in these studies. But somehow, because of fear of hyperkalemia or adverse events, sometimes there may be. But I have found that my prescriptions, when they go out to other nephrologists, what is the first thing that I see when these patients come back to me is that they have stopped ACE or ARBs, which was there in these patients, because they found that they had gone to them because the creatinine had gone up. I agree that maybe once in a while, if the patient is volume depleted, the ACE and ARBs may be stopped for some period of time, but it's very essential to restart these and stop ACE. And all these studies have again documented that even in advanced kidney disease, stage 4, stage 5 kidney disease, ACE and ARBs probably provide improvement as far as mortality, as well as even progression of kidney disease to end-stage kidney disease. So there is a residual risk And that's the reason for SGLT2 inhibitors as well as finerenone, which is available in these. Albuminuria is missed also in the US as well. This study shows that 80.7%, but these are primary care physicians. I thought nephrologists would behave much better, or at least because they are more knowledgeable about the albuminuria, and albuminuria should be an important risk factor for them. So I feel that this is something that was there. This I don't think needs to be. There is a residual risk which remains even after ACE and ARBs and Vijay. Now, what do I find commonly in patients from nephrologists? You find many times I haven't heard of IMAC, CKD, QD-Fort, Salicylarine. I don't even know what this Salicylarine is, and Renalog. These are commonly found in these patients. And this patient came to me that the pill burden was so high that, doctor, I am eating so many drugs. Can we reduce this drug burden? So that was the complaint with which this patient came. So I think I would like to put a plea. I don't think there is a better General Assembly of Nephrologists what Umesh has been able to. I would consider this to be the General Assembly of Nephrologists. So I would suggest that I think all of us, even including myself, I've started doing it now, that there could be a checklist which a patient in the OPD as a doctor, you should be able to sort of look at and maybe tick it. Did I look for albumin? Serum creatinine, all of us look at patients, get worried about this, increasing creatinines and all those. So, but albuminuria, I think, is missed many times. And it's not only that albuminuria should be quantified, but I think there is a treatment available now for albuminuria. There are good evidence-based medicines available. Fortunately, over the last decade or so now, SGLT2 inhibitors and non-steroidal mineralocorticoid receptor antagonists are available, and these are fairly well established, good scientific proof, 1A kind of evidences for treatment of albuminuria. So I think it not only needs to be quantified, it needs to be monitored so that we can see that the degree of albuminuria is reduced, and I think that's something. Home blood pressure monitoring, I'm sure many of you are using these days because this has been shown to be equivalent to an ambulatory blood pressure monitoring. I think the best BP level probably is the home blood pressure. So we should probably encourage our patients to get involved in the care of control of blood pressure. And in my opinion, if there is one factor which is the most important factor for progression of kidney disease is uncontrolled blood pressure. So if we can get good blood pressure control with ACE and ARBs and other drugs, obviously most of our patients would require more than 2 or 3 drugs. Whether ACE and ARBs have been included, I think we should have a checklist and look at it. Is this patient well enough to receive ACE and ARBs? And then we should look for a reason that no, he is not suitable for this. Then only probably exclude it in the list. SGLT2 inhibitors, similarly look at non-steroidal. And whenever you're giving sodium bicarbonate, I think we should look at sodium bicarbonate levels. Iron assessment, I'm sure these are fundamental things which are being done, but I looked at this prescription and over the last 2 months, and it surprised me. It surprised me actually. And I wasn't very sure that I know many of you would be also having similar kind of practices. I don't know what your experience is or what your feeling is about this, but iron assessment done in only 20% of patients before giving ESAs is something which I think we can do better than that. And I feel that the only way I feel that I can improve on my practice would be to keep a checklist of this and ensure that when the patient leaves, someone or myself, I look at the checklist. Vaccinations important again, another thing that can be prevented in our patients. And most important, the unnecessary drugs, the pill burden that is, I think each one of us must be. And many times you must also weigh whether the drugs that the patients are taking are they evidence-based? Because if we give lot of non-evidence-based drugs also along with as kidney medicines, many times they will forget to take the blood pressure medicines, which seems to be the most important factor, and might continue to take the kidney medicines for which the evidence is. Those are low-hanging fruits which are easily available to patients, but the pill burden is going to be huge, and therefore they're likely to miss these medicines. So ladies and gentlemen, I think I am putting this as a plea to this General Assembly, and I would like to hear from you as to what do you think, how can we, our own selves, improve the prescriptions that we give to our patients. I think I will stop here. Thank you very much for your patience.
I think these are the real words of wisdom by Bhishma Pitamah, Dr. Vijay Kher. The point that you raised regarding and the important values that people should be looking at is the albuminuria is very important. RN estimation is very important rather than prescribing ESS. And of course, there are drugs like ketone analogs and like people get prescription. What I've seen is Nephro-Save. And the patient says, sir, ये medicine तो बहुत जरूरी है. उन्होंने कहा कि kidney ठीक हो जाएगी. So all these things are there, and we should be looking up objectively at whether these things are required or not. Pill burden, definitely. Even I can't control myself when I'm writing. Maybe 14 number tak to chala hi jata hai, including vaccination and all that. Sometimes even 16. How to reduce that? We'll have to think about it.
Sir, regarding about this rhinoprotective, I mean, we also see prescription of dual blockade Arni plus this. So what would be your advice to this? Like adding all these 4 things together or 3 things together?
Dual blockades? No, dual
ARB
blockade
and ACE inhibitor together.
ACE and ARBs, no, I said either of these. ACE or ARBs as a combination now are out as such. By and large, you would not combine ACE and ARBs. You would use either ACE, optimize the dosages to control of blood pressure as well as for albuminuria, for decreasing albuminuria to the tolerable levels. And in most of the studies where SGLT2 or finerenone have been used, more than 95% of patients have been on ACE or ARBs. So it is only that you would use them as first drugs, then go on to use SGLT2 inhibitors.
No, there was old time when we used things to benefit both, but now definitely proven that both should never be combined.
Yeah, by and large, but although as a nephrologist, you might decide to use it for decreasing albuminuria in patients. If your blood pressure, you can tolerate, these patients can tolerate, then once in a while, I have an occasional patient who is on dual ACE and ARBs also. I'm sure some of you would have it, maybe an occasional patient, but this number is really gone down now from the earlier days when these drugs were combined. But yes, that's true.
I think another important point you mentioned, which should be brought out, you have already mentioned, about the advice about nutrition is zero. That is, unfortunately, many of the patients today are taking Tori and Loki. It is generally seen all CKD patients, I don't know who advises them, Tori, Loki, and whatever. They are not taking any dal. Everything is stopped. I think that is our duty again. We must tell them that carry on. ICMR says only 3% of Indians are taking normal protein diet. 97% are deficient. Our own
it is 0.6 grams, our normal population. And I think Santosh had made these we were doing it for ISN at one point of time, and he had picked up this study which showed that 97% of our patients, 9 out of 10 people are taking 0.6 grams of protein per kilogram. So for kidney patients, you prescribe 0.6 to 0.8 grams of protein. So there is no need for any protein. In fact, it is extremely important for nephrologists to tell them to take proteins because our regular patients are deficient of protein. So you should, in fact, encourage them to take high quality proteins because you're giving them lower amounts of protein. So I think
that point is very important.
Nutrition is very important. Malnutrition kills them multifold than kidney disease itself.
Because the Indian as such, many people, most of, I would say many people, they are vegetarians. And when the patient goes, they consult my dietitians. Everything is stopped.
No,
No dal, no vegetables, green vegetables, do things, sab band ho jata hai.
see, this is nothing that this is all of us know about these. It's only that in practice, when you see this happening and when you look at your own practice also, many times you feel vaccinations, many times I have missed, I have looked at them and the patients come back and I hadn't advised them. But if you keep a checklist, then you might be able to enforce it to more patients, because if I don't tell them, obviously they're not going to take it. If I tell them, they may still not take it, but at least you can maybe convince them more often to take these vaccinations and similar other things as well. So making a checklist.
No, the closure will be by Arjuna only. That, but last question.
So I'll take the liberties asking beyond this topic. So many times we have been doing when we do transplant, for certain things we usually, for example, we have anti-GBM wait for 6 months, SLE wait, all those things, PLR2R we wait for till the level is absent. But there are so many diseases where we do not know the the primary cause. So like we wait for these known diseases where they have the markers. In other conditions where we do not know the reason, what would you mean? Do you really wait for 1 year or to go after the initiation of dialysis because the disease, whatever idiopathic glomerular disease is still active? What do you do?
No, I would usually, I am a believer of preemptive transplantation by and large. We do at Medanta, we were doing 20% of our transplants were preemptive transplants, which is probably one of the highest in the country as such, I would guess. I usually feel that whenever glomerular disease subsides, and once they are subsided, especially say lupus, by the time patient reaches end-stage kidney disease, usually lupus is inactive. And I'm sure senior nephrologists here would agree with me that they will rarely see an active lupus at that point of time. And many other glomerular disease, vasculitis and all, by the time they reach fairly advanced kidney disease, I would, if the disease is not active, you would go ahead and transplant them. I don't want to wait for them to be on dialysis for some period of time. And so you would do it as such. And no.
I know, no. We were about, but I was going to tell Arjuna, Bhishma Pitamah had the right when to stop. We cannot stop.
No, I think I would say thank you very much for giving me this much of respect and all that. Thank you very much.